and good evening, ladies and gentlemen. Welcome to the 2022 China-US Anti-Cancer Association Summit. I'm Li Yan, Managing Director of the US-Chinese Anti-Cancer Association. I'm utterly thrilled and humbled to be your host for this exciting event, organized by China Anti-Cancer Association and the US-Chinese Anti-Cancer Association. First, I would like to welcome my longtime friend and collaborator, Professor Ying Wang, Secretary General of China Anti-Cancer Association, to make the opening speech. Let's welcome Professor Wang.
Thank you, Dr. Yan. Distinguished guests, ladies and gentlemen, good morning and good afternoon. It's my privilege to give a welcome speech at the opening ceremony of the 2022 China-US Anti-Cancer Summit. Firstly, on behalf of the China Anti-Cancer Association, I would like to extend my sincere thanks to USCACA and eChina Health for jointly hosting the Leading Cancer Summit. Secondly, I'm very pleased to take this opportunity to introduce who we are and what we do. CACA is the largest and the most influential cancer society in China and was founded in 1984 with 420,000 individual members and 103 professional societies. We play a leading role in cancer prevention, treatment, research, and education nationwide. And we work closely with global leading cancer organizations such as AACR, ASCO, and USCACA. In recent years, CACA has made significant progress on academic exchanges, including hosting the largest scale of cancer congress annually. In short, we call it CCO. Last month, we successfully hosted the 2022 CCO in Hangzhou with more than 148 concrete sessions, including 2 international sessions. The Congress attracted more than 20,000 participants in person and 425 million person time online. Today's summit will be the landmark of cooperation between China and the United States. We are honored to bring together the world-leading cancer leaders from 2 countries. It's extremely a milestone of our academic program, which provides us with a unique platform to share the top-level dialogues on anti-cancer to enable us to learn from cutting-edge findings and share the latest achievements in clinical practice and exchange perspectives on cancer management. Meanwhile, it will facilitate collaboration between China and the US to achieve the goal of reducing cancer burden globally and benefit cancer patients worldwide. United, we will be stronger. Let's work together to make cancer history. Finally, I wish the summit a great success, and we are looking forward to meeting you all in person next year. Thank you very much.
Thank you, Professor Wang. I'd also like to take this opportunity to thank you, Professor Wang, for all the wonderful collaborations and your support since the beginning of US-Chinese Anti-Cancer Association's journey almost 15 years ago. So thank you. Now I would like to welcome Professor Shi-Yong, President of U.S. Chinese Anti-Cancer Association and a Professor of Hematology and Oncology at the Emory University School of Medicine for his opening remarks.
Good morning or evening. Welcome to this China-US Cancer Summit. On behalf of the U.S. Chinese Anti-Cancer Association, USCACA, I would like to congratulate the opening of this important meeting. The mission of USCACA is to facilitate collaborations among Chinese American professionals in the field of cancer research, treatment, and prevention, to promote knowledge and information exchange between the professionals in the United States and China, and to provide education, information, and opportunity to serve cancer patients, the families, and the community. The participation of China Anti-Cancer Association, USCACA, AACR, and ASCO in this summit is timely, important, and significant, and current spatial situation, and should be a great opportunity to continue and facilitate our communication with the same goal of conquering cancer, a common and deadly disease that threatens human life. With this opportunity, we will learn about recent advances in targeting HIP protein for cancer therapy, the cancer research progress in the USA, the clinical oncology research progress in the USA, and the gastric cancer research progress in China. United and working together, we will go fast to find effective solutions to eventually control this deadly disease, making cancer a history. Therefore, I would like to express my appreciation for the chairperson, for all speakers, and for all other guests and participants. I would also like to give my special thanks to people from USCACA and China Health for the efforts to organize this important meeting to have this opportunity possible. And lastly, I wish the success of this China-US Cancer Summit, and wish everybody have a happy and safe holiday season. Thanks, and enjoy the meeting.
Great. Now it is really my privilege to introduce our keynote speaker for the event, the 2019 Nobel Prize laureate in Physiology or Medicine, Professor Gregg Semenza. Professor Semenza is a C. Michael Armstrong Professor of Genetic Medicine at the Johns Hopkins University School of Medicine. Dr. Semenza's lab made seminal discovery of hypoxia-inducible factor 1, HIF-1 alpha, a transcription factor that controls the expression of thousands of genes in response to changes in oxygen availability, for which he was awarded the Nobel Prize in 2019. He's also a very prolific researcher. He published more than 450 research articles and book chapters, and was cited more than 180,000 times. So for our summit, Professor Semenza is going to discuss targeting hypoxia-inducible factors for cancer therapy. Professor Semenza, please.
Dr. Yang, thank you for that very kind introduction, and I thank the organizers for the opportunity to speak here today. My purpose is to describe how a basic science discovery has been translated to the clinic in terms of novel cancer therapy. We started 30 years ago by studying the regulation of the human EPO gene, which is responsible for the production of erythropoietin, a hormone that controls red blood cell production. And EPO production in the kidney is increased when oxygen delivery to the kidney is impaired. And in an effort to understand the regulation of the EPO gene, we first identified a short DNA sequence just downstream of the gene, as now known as the hypoxia response element. And this sequence has the property that it can be taken out of the EPO gene, inserted into a heterologous reporter gene, and the expression of that gene will be increased under hypoxic conditions. We then identified a protein that was present in the nuclei of hypoxic cells that bound to this sequence, and we called this factor Hypoxia-Inducible factor 1, or HIF1. We then used the binding of HIF1 to the HRE as a way to purify the protein from 120 liters of HeLa cells grown in suspension culture. And we found that HIF1 was a heterodimer composed of HIF1 alpha and HIF1 beta subunits. The two proteins dimerize, they bind to the HRE, and they recruit proteins called coactivators that serve as a bridge to the transcription initiation complex at the promoter. In addition, these coactivators are histone acetyltransferases that can modify the chromatin, allowing the polymerase to access the DNA and transcribe it into RNA. And I was very fortunate that my first postdoc was Wang. He did his undergraduate training at Zhejiang University in Hangzhou, did his PhD at Arizona State University, and came to my lab in 1992 and played a major role in the purification of HIF1. It turned out that the HIF1 alpha subunit was regulated by oxygen availability in a very direct manner. 3 laboratories reported that there were 2 proline residues in HIF1 alpha subject to a post-translational modification called hydroxylation. And this is carried out by a series of prolyl hydroxylase domain proteins that use oxygen and the glucose metabolic intermediate alpha-ketoglutarate as substrates. One of the oxygen atoms is inserted into a proline residue of HIF1 alpha, and the other oxygen atom is used to split alpha-ketoglutarate into CO2 and succinate. The hydroxylation of HIF1 alpha under normoxic conditions enables the protein to be bound by the von Hippel-Lindau tumor suppressor protein. And when VHL binds to HIF1 alpha, it recruits a ubiquitin protein ligase, leading to the ubiquitination and the proteasomal degradation of HIF1 alpha under normoxic conditions. Under hypoxic conditions, the reaction is inhibited. The non-hydroxylated form of HIF1 alpha cannot be bound by VHL and is not degraded and rapidly accumulates within hypoxic cells. There's also an asparagine residue in the transactivation domain of HIF1 alpha that's hydroxylated by a protein that we originally identified and named FIH1 for factor inhibiting HIF1, because we showed this protein binds to HIF1 alpha and inhibits its transcriptional activity. And it turned out that FIH1 uses the same biochemistry as the prolyl hydroxylases to hydroxylate an asparagine residue. And when this occurs, the coactivators cannot bind to HIF1 alpha. Again, under hypoxic conditions, the hydroxylation reaction is inhibited, the coactivators can bind, and HIF1 is competent to activate transcription. So you can appreciate that both the half-life of the protein and its specific activity are being regulated by these oxygen-dependent modifications. And this provides a mechanism to directly transduce changes in oxygen availability to the nucleus as changes in HIF activity. Well, we started out by identifying the EPO gene, and we now know of over 8,000 different RNAs whose expression is increased under hypoxic conditions through the activity of either HIF1 or its sibling HIF2. Some of these genes code for proteins that serve to increase oxygen delivery. So EPO increases systemic oxygen delivery, whereas vascular endothelial growth factor stimulates angiogenesis, which provides a mechanism to increase oxygen delivery locally. Then at the cellular level, individual cells must adapt their metabolism to survive oxygen deprivation. And the classic metabolic adaptation is the switch from oxidative to glycolytic metabolism that's mediated by HIF-1. Well, this beautiful homeostatic system is hijacked by cancer cells. This is a picture of a advanced aggressive human cancer, and you can see these areas of necrosis where the cancer cells have died because they're too far away from a blood vessel to receive adequate oxygen because it's been consumed by all of the intervening cells. And then you can see these intensely brown stained nuclei, which have been stained with an antibody against HIF-1 alpha. And you can appreciate that the viable cells that are furthest removed from the blood supply are intensely expressing HIF-1 alpha. What we and others have found is that increased HIF-1 alpha levels in the primary tumor biopsy is predictive of an increased risk of patient mortality. And this has been seen in many different solid human cancers. And what we know is that the rapidly dividing cancer cells that are surrounding blood vessels are the cells that are targeted by chemotherapy and radiation therapy, whereas the hypoxic cells are the cells that are most likely to survive these therapies. They're the cells that have invasive and metastatic properties, are able to evade the immune system, and we believe these are the cells that are most likely to kill cancer patients. Yet until recently, there were no therapies targeting hypoxic cancer cells. And the reason that HIF-1 alpha expression is associated with cancer mortality is that the HIFs control the expression of genes that contribute to every critical aspect of cancer progression. And today I'll be focusing mostly on the role of the HIFs in immune evasion. Well, while in many cases, hypoxia is the stimulus within the tumor that leads to the expression of the HIFs, there is one example in which the stimulus is genetic in its origin, and that's in the von Hippel-Lindau hereditary cancer syndrome. And in this cancer syndrome, affected individuals have a germline mutation of the gene encoding VHL. And the other VHL allele is inactivated in kidney cells, and this leads to the development of clear cell renal cell carcinoma. And you see it gets its name because the cytoplasm of the cancer cells stains very poorly with hematoxylin and eosin. But you can see the very intensely brown stained nuclei because, again, we've applied an antibody against HIF-1 alpha, and you can see that all of the cancer cells in this section are intensely expressing HIF-1 alpha. And if we take these cells out of the tumor and put them into culture and look at the expression of HIF-1 alpha and HIF-2 alpha, we see that the proteins are expressed regardless of whether the cells are grown under high or low oxygen conditions. Because in the absence of VHL, the oxygen-dependent degradation of HIF-1 alpha and HIF-2 alpha is blocked. If we return a wild-type copy of the VHL gene to these cells, we restore the normal oxygen-dependent degradation of HIF-1 alpha and HIF-2 alpha. But whereas these cells will form tumors if injected into mice, these cells will not. So it's the dysregulated expression of HIF-1 alpha and HIF-2 alpha that are critical for the development of clear cell renal cell carcinoma. about 10 years ago, Kevin Gardner's laboratory identified a pocket in the HIF-2 alpha protein that could be perturbed by small molecules. And from this discovery, a small biotech firm, Peloton, developed this compound, which binds tightly to HIF-2 alpha in this pocket and blocks its dimerization with HIF-1 beta, thereby inactivating HIF-2. And it turns out that in clear cell renal carcinoma, HIF-2 alpha is the principal driver for cancer progression. And so this selective HIF-2 inhibitor was tested in clinical trials of patients with advanced renal cell carcinoma. And this is from one of the phase 1 trials, a remarkable result in which there were a very large number of partial responses and of stable disease, an 80% disease control rate in a phase 1 trial of patients who had failed existing therapies. This drug, which is now known as belzutifan and marketed by Merck, was approved by the US FDA for the treatment of renal cell carcinoma and other VHL syndrome-associated tumors last year. And so this is the first translation of the discovery of the HIFs to the clinic in terms of an FDA-approved drug. We've been interested in targeting the HIFs in hepatocellular carcinoma, which is the third leading cause of cancer death worldwide. It's the most rapidly growing cancer diagnosis in the US over the last 2 decades. And the oncologists in China will know that this has been a major cause of cancer in China for a long time, with over 300,000 liver cancer deaths per year in China. Most hepatocellular carcinoma patients have advanced disease at the time of diagnosis, and as a result, there are few treatment options with a 5-year survival of less than 15%. The first approved drugs for the treatment of advanced hepatocellular carcinoma were the mixed kinase inhibitors, such as sorafenib and levantinib, that provided only modest survival benefit with low response rates, high toxicity, and frequent development of resistance. The immune checkpoint inhibitors have been tested in a number of trials. Nivolumab, an anti-PD-1 antibody, was granted FDA approval based on phase 2 trial data, but the phase 3 trial of nivolumab versus sorafenib as first line did not meet its primary overall survival endpoint. A phase 3 trial of pembrolizumab, which is another anti-PD-1 antibody, versus placebo as second line was also negative. Most recently, a trial which combined nivolumab with ipilimumab, an anti-CTLA-4 antibody, resulted in a 33% response rate. But as you know, when these drugs are combined, there's a greatly increased risk of autoimmune responses in which the body begins to destroy normal tissue. We performed a cell-based screening assay and identified this small molecular weight compound, which, as you can see, is a bis-bromoindol thiazole, as a specific inhibitor of HIF activity. It has at the moment, the unglamorous name 32134D. In this experiment, we injected human Hep3B hepatocellular carcinoma cells into immunodeficient mice. And when the tumors reached a volume of 100 cubic millimeters, we started treatment either with vehicle or increasing amounts of this novel HIF inhibitor delivered by intraperitoneal injection on a daily basis. And you can see we saw a dose-dependent inhibition of the tumor growth with a maximum therapeutic dose of 40 milligrams per kilogram per day. And you can see even at a dose that was above the maximum therapeutic dose, we saw no effect on body weight or on the appearance or behavior of the mice. At the end of the experiment, we harvested the tumors and analyzed the tumor lysates for the presence of HIF-1 alpha and HIF-2 alpha protein. And you can see these proteins are highly expressed in tumors from vehicle-treated mice, whereas the proteins are virtually absent in tumors from the animals treated with 32134D. So this compound causes the degradation of both HIF-1 alpha and HIF-2 alpha. Well, when we harvested the tumors, we noticed not only were they smaller and weighed less, but they also had a very different appearance in which they were much paler than the tumors from the vehicle-treated mice. And when we performed immunohistochemistry using an antibody against CD31, we saw very large blood vessels in tumors from vehicle-treated mice, whereas tumors from mice treated with this novel HIF inhibitor, the blood vessels are present, but the vessel area is greatly reduced, meaning that the perfusion of the tumor is significantly impaired. And this was due to a decreased expression of a number of angiogenic growth factors, as we were able to show by ELISA using tumor lysates. We saw significantly decreased expression of vascular endothelial growth factor A, stromal-derived factor 1 alpha, erythropoietin, and stem cell factor, or KIT ligand. So the HIF inhibitor can block the expression of multiple angiogenic growth factors and impair tumor vascularization. We also used a mouse model of hepatocellular carcinoma, the HEPA-1/6 cell line, and we injected these cells into syngeneic C57L mice. And when we treated tumor-bearing mice with a isotype control antibody, we saw very rapid tumor growth. When we treated with an anti-PD-1 antibody, we saw some reduction of tumor growth. In several cases, it appeared that the tumor had been eradicated, but after we stopped the treatment, several tumors recurred for a durable tumor eradication rate of 25%. If we treated with the HIF inhibitor, we saw a marked inhibition of tumor growth and eradication of the tumor in a third of the mice. And when we combined these two therapies, remarkably, we were able to eradicate the tumor in 2/3 of the mice. So we increased the response to anti-PD-1 therapy from 25% tumor eradication to 67%. And of course, if we could achieve this in patients, that would be a remarkable advance. So we were interested in trying to understand how did the HIF inhibitor sensitize the tumors to anti-PD-1 therapy. And to answer that question, we prepared tumor lysates and performed flow cytometry and quantified the percentage of CD8 positive T cells and natural killer cells within the tumors. These are the cells that mediate anti-tumor immunity and are the cells that must be present for anti-PD-1 therapy to be effective. And you can see that treatment with 32134D alone resulted in a significant increase in the percentage of CD8 positive T cells and natural killer cells. In addition, there were significant decreases in the percentage of tumor-associated macrophages and myeloid-derived suppressor cells. These are the cells that mediate immunosuppression and resistance to anti-PD-1 therapy. So you can appreciate that the HIF inhibitor has dramatically changed the tumor microenvironment from an immunosuppressive microenvironment to one favoring anti-tumor immunity. And the basis for this at the molecular level was an increase in the levels of CXCL9 and CXCL10 within the tumors. These are the chemokines that are responsible for the recruitment of CD8 positive T cells and natural killer cells. In addition, there was decreased expression of VEGF-A and also interleukin-10. And these are two cytokines that are responsible for the recruitment and the maintenance of tumor-associated macrophages, myeloid-derived suppressor cells, and the regulatory T cells which also mediate immunosuppression. So the effects of 32134D in hepatocellular carcinoma are it induces degradation of HIF-1 alpha and HIF-2 alpha as its mechanism of action. It blocks the expression of multiple angiogenesis factors. It converts an immunosuppressive tumor microenvironment to one favoring anti-tumor immunity, and it sensitizes hepatocellular carcinoma to anti-PD-1 therapy. And we're hopeful to bring this drug to clinical trials in the near future. All the work with the inhibitor that I described was performed by Shaima Salman, a very talented postdoc in the lab. This is my lab. We're very fortunate to recruit people from all over the world who have a passion for scientific research. Thank you very much for your attention.
Great, thank you. Thank you, Professor Semenza, for sharing with us so wonderfully condensed the 30 plus years of work. And it is also really, myself is really expecting to see important translational work of the HIF-1 inhibitors. And hopefully we're going to see some clinical data in the near future. Thank you for highlighting all the value of good and solid basic research. So thank you. So it is now my great pleasure to welcome our next speaker, Professor Fan. Professor Fan is the president of China Anti-Cancer Association, and he is also the member of the Chinese Academy of Engineering, international member of the US and the French National Academy of Medicine. He's a renowned GI oncologist, and his clinical research, as well as basic research into digestive diseases, especially in GI cancers, has been very proliferative, producing about 160 books and also over 700 peer-reviewed publications. His contributions were recognized by numerous prestigious awards, both in China as well as internationally. Professor Fan is also a beloved public speaker who is able to really master in discussing complex medical topics in a very simple and humorous language. And he always gives people surprises. And as for today, I just got a good surprise about 30 minutes ago before we start this summit. Professor Fan is actually going to give a presentation without slides. And his presentation is going to be the journey of integration of cancer prevention and treatment in China. So let's welcome Professor Fan. And for those English-speaking speakers, you could use the interpretation, that button at the bottom of your Zoom, and you should be able to choose English and Chinese. Professor Fan.
Dear Mr. Chairman, distinguished professors, ladies and gentlemen online, it is my great honor and the privilege to be invited this summit. I'm from Shi-Yong. You know, the Shi-Yong is a very ancient city, terracotta here. If you as an ancient capital, it lasts in 13 dynasties, more than 1,000 years. So my foreign friend told me, no one has not been to China if you'll never been to Shi-Yong. So welcome to Shi-Yong. So today I would like to speak in Chinese. After panel discussion, I will in English. Because maybe it's on schedule. I prepared the slides to introduce my small work, but I changed my mind, and so because after me, there are two very important presentation. One is the presenter from AACR, who were talking about the basic science, basic research of cancer in USA. one another is the president of ASCO, Professor Winner, will tell us about clinical progress in USA. As the president of CACA, so for better exchange and collaboration, I would try my best to say something. What is CACA think? What we are doing? So from now on, so I will speak Chinese for the more quickly, because we have three speakers from USA. The total time is 15 minutes. For me, just 15 minutes. So I would like to speak quicker. And so, 那么今天呢
Okay, today I would like to talk about our ideas and our protocols in treating cancer. Well, specifically, what we have just established the guidelines of CACA. Well, with two versions in both English and Chinese, with more than 3 million and 3 million words. Well, because the cancer patients in China accounted for more than 1/4 of the whole population in the world. And every day in China, there are more than 8,000 cancer patients die from this disease. But for such a long time, we just refer to the guidelines in foreign countries like ISMO, like ASCO. Well, we have made progresses and benefited the patients, but data that we cannot ignore, that in the US, we use the NCCN guidelines, they treat the patients. Well, the 5-year OS almost reached 70%, but using the same guidelines in China, we'll use it individually, but we only reach like 40% of the 5-year OS rate. So what's the question? What's the problem here? That's the problem that we think all the time, because the guideline is updated continuously, because there is space for improvement, and this is the same for all the guidelines. We cannot wait for your improvement, for your guidelines. Well, because for the spaces for the improvement is the places that we need for the Chinese patients. And we know that cancer is the same disease, but caused by different reasons. So we should have different strategies to treat the cancer. For example, the lung cancer, smoking is a factor that causes lung cancer. But can we just stop lung cancer with stopping smoking? The answer is no. Well, we cannot. Well, but in China, it is not the circumstance that we can stop smoking, but we cannot stop breathing. So it is not only the contribution to the scholars in the oncology field. Like, well, recently, all of us, we wear the masks. Well, but the decrease of the incidence of lung cancer, well, this trend, the decrease of the trend of lung cancer may be very obvious in China. And also for the liver cancer, which ranked the second place in China. Well, in the US, well, most of the liver cancer is caused by HCV, but in China, most of the liver cancer, they are caused by HBV. So after the treatment of a tumor with the antiviral diseases, there is a very small chance of recurrence. But in China, it is much more difficult for treat the HBV-caused liver cancer. So here, is it still the contribution of the oncologists? It is more the contribution of the experts in the epidemiology. So also we have this HP-caused gastric cancer. We should eradicate the infection of HP. to treat the gastric cancer. Well, the infectious rate of HP in China passes over 60%, but it is not the same in the US. So before and after the eradication of the infection of HP, they do not have the same results. So it is not only the contribution of the oncologists, but the contribution of the GI physicians. So also, it's the same circumstance with the esophagus cancer patients. Well, in China, it is mostly ESCC, but in the US, it is adenoesophagus cancer. So the ESCC is mostly related to the dietary habit. But in the US, this cancer is mostly caused by the GERD, the reflux. So if we use the similar protocols to treat the same cancer, they will have different results, different final prognosis. And another example, well, the breast cancer. Well, in China, we have younger patients, and also the disease is more mortality, it's more mortal. So it is also different with those breast cancer patients in the US. It is related to the economic progresses in the two countries, like their habits of wearing the inner clothes. So these habits, these little habits, influenced by the cultural background, their living lifestyles, they will also make the difference of the reasons causing the breast cancer. So they have different contributions from different factors. So for the different two countries, they have different circumstances. So we should have different emphases even in the treatment of the same disease, of the same cancer. So under these circumstances, we just organized in CACA in the last 5 years. We have expanded the population of the members in our association from the 50,000 to now over 420,000 to have different ideas converged here. And also we have held these great scale of national annual meeting to have this platform of communication and exchanges of different specialties to converge the wisdom and to have standardized practices, and also to form these books, these important chapters of our important books. We have these important books written with a weight greater than 16 kilograms. We just collected all the data from all over the world and to find the places that we can improve. And also we have organized this academic journal with Springer to promote the Chinese experiences and also to import the foreign experiences in treating cancer. So someone, they just asked, there are so many academic journals about oncology. Why do you have another one? Well, my answer is that so many journals on oncology, ours is different from them because we can use this academic journal to really treat the patients. So we have this annual meeting, we have this great books, we have this academic journal. We are all ready for forming this CACA guidelines. And we have formed so many experts to focus on more than 51 kinds of cancers to form these integrated guidelines of CACA. So with the publication of these guidelines, we also promoted to the other country with the English version. After we issued these guidelines, we had this tour to give these guidelines in the whole nation. We have already held over 22 2,500 lectures to the public, to the professionalism. So this is about our tour of the lectures. So this guideline, we already promoted nationwide.
The second point is that when we look at China's attitude towards cancers, we are complementary with each other because we were talking about HIM or HI oncology. And the first thing is about the fact that the tumor will grow. And then that means that there is the seed, then there is environment, and then there is the nature force of the human body. So it's really the comprehensive interaction. Then it really is about whether the seed will grow to a tree when you bury it into the soil. It's not only about the seed, but also about the climate and about the other factors surrounding it. And in the Western medicine, there is more about the cancer cells. So there is the subcells, molecular level, etc. And we also know that in China, we proposed the holistic integrative oncology in 2010. 5 years later, there is precision medicine proposed by the US. So why precision medicine? Our understanding is that for the evidence-based and translational medicine, they are complementary to the others. So when it comes down to the oncology, that means if one sequencing cannot work, 100 sequencing cannot work, then we want to have 1 million sequencing tests, because science has already published the papers by saying that. We have the 50 single-cell sequencing, and the results will not give you the same mutations. Natures have also published the paper. So if we have 5,000, but they are still different in the results. So if we have the sequencing for 1 million, we hope to find the tumor gene or oncogene, and then we can treat targeted the oncogene. But right now, according to the summary, we say that there's no single gene that will not involve tumor, not a single tumor that will only involve one gene. So that's the result. And when you look at all of the genes in the embryos, while we were in the womb, we've seen them, only that they've been turned off. Isn't that the case? So with that, just yesterday evening, I was looking into the Starry Night. I thought that all the stars belong to me, would watch me. Actually, the stars do not necessarily watch me, because when I enter the room, the stars are shining outside still. So we're not saying that the precision medicine is wrong. It is right. But the only thing is that we need a holistic integration. Without the holistic approach, but only single-handed approach, then every method alone or approach alone has already been saturated. You will not be able to cure if we bombard with everything. We have the tumors are bombarded, but also the patient is bombarded. Or maybe the tumors have not been dead yet. The patient has already been bombarded. So we really need a holistic approach. In China, I think alternative and supplementary in the US is completely different, because we introduced the concept of the traditional Chinese medicine, TCM. We know that it's about 200 years from when we introduced the Western medicine to China. So before Western medicine got into China, we have only the traditional Chinese medicine. So in 5,000 years ago, we didn't have TCM, but we still treated the tumors. But in TCM, there is only the treatment of the manifestations. So it's a holistic view. We do not call it as the tumor treatment. So in the TCM, there is a lot of the concepts. We cannot forget about them. And for example, we have identified the fact that ophthalmic trioxide, and that is used for the treatment of APL, that is really effective. And that means that several thousand years later, the whole world is even using that. And artemisinin, we know that this is extracted from a plant, and that is to control malaria, and that plays a very effective role. So that's why we have got the Nobel laureate, Mr. Tuyoyo, for that reason. But then we noticed that not only can that inhibit the resistance of the bacteria, but also the tumor cell resistance can be turned around. It's very effective. And in TCM, 2,000 years ago, we already raised the microbiome to treat diseases. But right now, we have the chemotherapy issues and radiation therapy. There might be multiple drug resistance, but we don't need to move on the tumor cancer cells. We just need to change the microbiome. And then we can sensitize the cancer cells to chemotherapies. So that means in the future, we will have some traditional approach that's been for thousands of years of history, and integrate that and combine that with the Western medicine. And the third aspect we are working on is that when we look at the tumors overseas, of course, there is the ASCO and ESMO guidelines which stress the diagnosis and treatment and also stress the therapies. But our guideline is different. Why is this guideline so thick? The reason is that we have introduced the prevention screening, treatment, and rehabilitation. 1/3 of the tumors can be prevented. So that's really about the first step. We don't need to work that hard. The second is screening. And how do we really screen them? For example, in China, I'm the GI doctor. And in many cases, I would have 260 endoscopes, but most of them are not for those who have had the tumors at all. But for whole China, we have tens of millions of endoscope performances. And if we can target them to the population that are high risk, not the low risk, then we will be able to screen the early stages. Then we will get very good results. So I will skip the diagnosis and treatment, but now the last one is rehabilitation. After treatment, it will completely be different whether you have the rehabilitation or not. So in CACA, we have over 400,000 members, and we have follow-up every one of them. And then we guide their and manage their life. For example, for the lung cancer patients, because of smoking, and after going back home, they continue to smoke, and the colorectal cancer patients continue to have the fried food when going back home. They are wrong. So the guideline, firstly, is about the prevention, diagnosis, treatment, screening, and rehabilitation.
So we call that the holistic integrative mental health. Yeah, 这是一个。第二个，我们现在正在
so that's the first, and the second is that we're developing another guideline, and that's on the technical side. That is to treat a patient. We have a visit, we have so many options. How do we choose? So the second guideline is called Holistic Integrative Regimen of Cancer. Then that's about how to treat or deal with the patient. The previous guideline can be understood as the one for the disease. And the second is really about technologies or techniques. There are pros and cons listed. We have already written the second guideline for 59 approaches. And also out of the 59 approaches, we have already modified them. We have also the 5 words. The first is evaluation, and then assessment is the first. So we do not go for the surgery immediately when they have the visit. We have to assess. So what do we assess? 50% of the cancer patients have anemia, but 92.8% of the anemic were not corrected before they were treated. So that's just adding oil to they just pouring fuel to the fire. So that's 70% of the patients who were not assessed before they were treated. And also we need to assess the whole body situation. Then supportive, so supplement. So we need to help them with the nutrients if they are running short of that, or the mental strength so that they can be competent enough for the treatment. And the third is the control. So we use different methods to really slate out the individualized therapies to control the tumor cells. We do not propose killing the tumor cells. We do not say that as the anti-tumor, even though we're called the Anti-Cancer Association. But the reason is that everyone has a tumor cell. Only to a certain extent, when it grows to a certain size, can it be called as the tumor. So we control it. If you kill it, there are some problems. Of course, we will kill some of them. However, when you kill, you usually would kill yourself by 80% too. And when you have got 1,000 soldiers out, launched at them. So the fourth is about the protection of the organs, the normal functions. We know that for tumor patients, a lot of those died because of their impaired organs. And we know that for the hyperkalemia, for example, there is a lot of injury to the kidney and the livers, but not tumors. So that means all the other treatment would impair the other organs. For example, surgeries would be mechanical injury, chemotherapy is a chemo injury, radiotherapy is also physical injury, and biotherapy is about medical injury and the psychiatric injuries. So if we have no protection, there are going to be problems. So we have the 15 methods for protection of the organs. So in CACA, we have hepatic oncology that is about killing the tumors. We also have the oncohepatology. So they don't know about the tumors. They know how to protect the liver, kidney, and heart. And then surviving. And that means when we treat the tumors, yes, we resect them, we shrink them, and a certain indicator has to come down, but that's not efficacy. It's only one indicator of efficacy. More about the surviving. One is about the survival extension. The second is quality of life. Then we should evaluate which is better or not, which physician is better than the other. So that's about assessment, supplement, the control, protection, surviving. So after we have got the second guidelines, it's about 10 million characters, and we call them as the CACA guidelines. And then they've been translated into English. And that's why we say that we used to benefit from the overseas therapies. And huge success has been achieved, but our summary of experiences might also serve as your reference. And 70 out of 100 tumor patients can survive 5 years. And we introduce your methods, and then we can see 40 to survive. But of course, there are 60 remaining. We need to work hard on them. So we might also get some of the insights that can help you address the 30% that are not surviving. And they might serve as a good reference for you too. So this is the work by CACA for your reference. And that will be all from me. Thank you, everyone. And I think that I have also used up my time, probably over around, sorry, but in the panel discussion, you can ask me a few questions to give you back at the time. Thank you.
Congratulations on the 16-kilogram tailored guideline for diagnosis treatment of cancer for patients in China. I do hear from you that different etiology, genetic and environmental factors in China versus those in the US do require different and holistic approaches. Very meaningful work for hundreds of thousands of cancer patients in China. And we're now hopeful that the 5-year survival for cancer patients in China will soon catch up with the 70% as in the US. So thank you. Now I'd like to welcome our next speaker, Professor Lisa Coussens, President of American Association of Cancer Research, AACR. Dr. Coussens is a chairwoman of the Department of Cell and Developmental Cancer Biology, and she's also the Associate Director for Basic Research in the Knight Cancer Institute at Oregon Health and Science University. Her current research focuses on dissecting the roles of normal immune cells in solid tumors. And what is really exciting is what Dr. Coussens' research is now being translated into clinical trials in combination with chemotherapy for different tumors, including triple-negative breast cancer, pancreatic cancer, head and neck. And she has been acknowledged with multiple awards in recognizing her research contributions as well as her leadership in promoting women in science and research. So her presentation is Discovery Science Driving Clinical Breakthroughs. Professor Coussens, please.
Thank you very, very much, Dr. Yan, and the other organizers for inviting me to present today on behalf of the AACR, the American Association of Cancer Research, for which I am the president from the 2022 to 2023 period of time. Today, what I would like to do is to present results that have been recently published, developed by the AACR, that document how basic science research and basic science discoveries have fueled progress in cancer research that is now translated very effectively to the clinic and impacted overall patient survival with many different approaches to improve quality of life and outcomes for patients with various types of cancer. I'd like to start by providing just some statistics that I think are really quite impressive. Starting from 1991 to 2019, of which is the last year where we have significant statistical data, the overall cancer death rates in the United States has declined by approximately 32%. For the United States, this equates to approximately 3.5 million individual lives being saved. As of January 2022, with the saving of that many individuals, that has resulted in 18 million current cancer survivors living in the United States. And as you can appreciate, with that many individuals surviving cancer, it's also now very important to collect survivorship data to understand how surviving cancer impacts quality of life in general and other aspects of chronic disease that are associated with an aged population. Moreover, in the United States, the 5-year relative survival rate for all cancers has increased from 49% for people diagnosed in the mid-1970s to nearly 70% for those diagnosed from 2011 to 2017. And very importantly, among U.S. children and adolescents, the overall death rates have declined by more than 50% over the last 50 years. These are very significant changes in how individuals are diagnosed, but also treated to impact their overall outcomes. As a basic scientist, I'm very proud of the fact that most notably, many of these positive impacts emerged out of remarkable funding for basic science that has been translated to the clinic through collaborative processes with basic scientists and our clinical colleagues that have then done clinical trials and evaluated tolerability, safety, and efficacy in a series of clinical trials involving hundreds to thousands of patients, depending upon the disease. And so just as demonstration of how impressive this pipeline is, in just the last year, 8 new therapeutics for treating patients with various types of cancer have been approved by the Federal Drug Administration here in the United States. 10 previously approved therapeutics were enabled for treating additional types of cancer beyond which initial FDA approvals were initially provided. And importantly, 2 new diagnostic imaging agents have received FDA approval that help us go much deeper in identifying patients that have malignant disease, but also enabling us to monitor response to prospective responses to individuals that are receiving various types of anti-cancer therapeutics. What I'd like to do in the next several slides is just walk you through 3 notable examples where a bench to bedside and back to the bench type of a pipeline has enabled FDA approval of 3 remarkably successful drugs, most notably relatlimab, asciminib, and belzutifan, which was beautifully described by our keynote speaker, Nobel Prize winner in 2019, Dr. Gregg Semenza, along with colleagues Bill Kalin and Professor Ratcliffe. So as an example, if we think about when the LAG3 gene, a very important gene in impacting how T cells respond to pathogen infections, tissue assault, and notably cancer, the LAG3 gene was identified over the last 25 to 30 years, along with several other molecules that are now commonly identified as checkpoint inhibitor molecules because their protein functional effect is in regulating T cell cytotoxicity, proliferative capability, and antigen-dependent killing of damaged cells or malignant cells. We think of the pipeline since the early 90s when the first T cell growth factor was identified, interleukin-2. We've seen remarkable progress from basic science in studying just the fundamental basic biology of how T cells play a role in maintaining tissue homeostasis and protecting the individual from untoward histopathologies. We've now seen remarkable progress in identifying these targets and translating 4 of them into very effective drugs that have enabled that improved response rates to cancer in the form of therapeutics. And the 4 approved targets at this point in time, most notably are CTLA-4, PD-1, PD-L1, and most recently LAG-3. So relatlimab is a human IgG4 blocking monoclonal antibody that restores the effector function of terminally exhausted otherwise cytotoxic T cells. LAG-3 is a protein that's expressed by several different types of immune cells and is used as a receptor for proteins on malignant cells in order to evade detection by the immune system, most notably to avoid detection by T cells. Identification of LAG-3 initially happened in 1990, and subsequent studies over the last 30 years have led to approval now of a drug targeting specifically LAG-3, relatlimab, in 2022, earlier this year. This has been the first approval in the last 8 years of a novel immune checkpoint target. The combination of Opdualag is a combination approach that targets LAG-3, but also targets PD-1 that's expressed on cytotoxic T cells. And this is marketed in North America under the trade name Opdualag. Very effective new therapy in targeting several different types of malignancies. Next, I'd like to just point to remarkable success in the hematologic malignancy space that comes out of fundamental discoveries that happened over 60 years ago in recognition of a fusion, an abnormal chromosome 22 fusion that happened in chronic myelogenous leukemia patients, most notably recognized as the Philadelphia chromosome. That is an abnormality with a fusion between chromosome 22 and chromosome 9, creating a fusion with translocation of the proto-oncogene ABL from chromosome 9 onto chromosome 22. That BCR-ABL fusion protein has been identified as a driver to tumor promoting factor in chronic myelogenous leukemia. And in 1990, this was evaluated in mouse models of chronic myelogenous leukemia and shown that simple fusion was a driving event that could induce and promote full CML malignancy. In the early 1990s, various screening strategies were undertaken to try to identify a way to inhibit the kinase activity resulting from this fusion and protein production of the BCR-ABL fusion that led to FDA approval of a drug referred to as imatinib, which was a very important milestone in that imatinib represented one of the very first molecularly targeted agents based upon diagnostic criteria in bringing in and shepherding in the advent of modern precision oncology. Approval of imatinib was followed with dasatinib to treat imatinib-resistant disease, imatinib originally being approved in 2001, and dasatinib in 2006. Subsequent to this, there have been several additional therapeutics that target this very potent kinase that have received FDA approval. The most recent is asciminib, or also the trade name Scemblix, a first-in-class allosteric inhibitor of the BCR-ABL1 kinase activity that's now approved for treatments of patients with chronic phase of chronic myelogenous leukemia. So whereas CML used to be a very significant and almost a fairly rapid death sentence, now by precision oncology approaches identifying these fusions and abundant BCR-ABL kinase activity, there's now an entire shelf of drugs that treat primary disease, but then also are able to very effectively treat resistant disease, which is very important. The third drug that I wanted to highlight that also stems out of fundamental discoveries in the laboratory were really beautifully articulated by our keynote speaker, Dr. Semenza. And that's with the recognition that the VHL downstream or in regulating hypoxia, a critical component of tissue homeostasis, but also a component that is co-opted by tumors to enhance tumor cell growth. In recognizing how VHL and HIF proteins form a complex, HIF inhibitors have been developed, as Dr. Semenza articulated, the most recent being the belzutifan or Welireg, which is a hypoxia-inducible factor inhibitor for patients that have VHL-driven disease that require therapy with regards to associated renal cell carcinoma, central nervous system hemangioblastomas, and also pancreatic neurocrine tumors or PNETs that don't require immediate surgery. This drug is showing tremendous efficacy in these diseases where the VHL gene is also activated. And so bench to bedside translation hasn't just happened in the context of identifying targets for effective therapy. Bench to bedside also implies improved diagnostics and improved tools with which to evaluate modern sophisticated technologies. Very importantly, in today's day and age of modern medicine is the contributions of artificial intelligence-driven programs that assist clinicians in identifying disease, but also in predicting outcomes for patients with identified disease. This slide identifies 4 artificial intelligence-driven software programs that help clinicians to identify precancerous lesions within histopathologic FFPE sections, most notably now for tissues in routine colonoscopy. Other programs are very important for enabling AI-guided digital review of prostate cancer or potential prostate cancer biopsies. AI-driven softwares are also being utilized in radiographic images for interpreting mammographic breast density and predicting which women who have particularly mammographic dense breasts might be at enhanced risk for malignancy. And more recently, we're seeing AI-driven approaches also being used for individuals with precancerous polyps within the colon. Very important data science-driven approaches utilizing the power of artificial intelligence. We've also seen basic science methodologies and platforms translated into imaging agents, as well as theragnostics that help us identify precancerous lesions in situ, as well as in imaging various diagnostic imaging approaches. In November of 2021, the FDA approved Citalux, which is the first tumor-targeted imaging agent utilized for ovarian cancer. This assists surgeons to visualize hard-to-detect lesions in adult patients with ovarian cancer during surgery, so they're able to evaluate whether or not surgical resection margins are clean or perhaps surgical resections need to be expanded. More recently, earlier this year in March, the FDA approved Pluvicto, which is a labeled version of the PSMA, or prostate-specific membrane antigen protein, which is utilized to detect for the treatment of adult men with castrate-resistant prostate cancer who have been treated previously with a combination of an androgen receptor inhibitor, most notably enzalutamide, along with chemotherapy. This agent is a radioactive diagnostic agent, the very first radioactive diagnostic agents approved for selection of patients for radiotherapy that fulfill these criteria. The other notable bench-to-bedside discoveries are in the form of immune therapies, where we've just seen remarkable success by tethering various forms of immune checkpoint inhibitors along with molecularly targeted agents in combination with various forms of cytotoxic therapy, that being either chemotherapy or radiotherapy. In March of 2011, the FDA approved the first immune checkpoint inhibitor, ipilimumab, that targets the CTLA-4 molecules most notably expressed on CD4 positive T cells in metastatic melanoma. Nearly 4 years later, a second immune checkpoint inhibitor, pembrolizumab, also known as Keytruda, was approved also for metastatic melanoma. Since then, another 7 immune checkpoint inhibitors have been approved by the FDA, including atezolizumab, avelumab, cemiplimab, quite a few additionals targeting PD-1, PD-L1, CTLA-4, and most notably, recently, the anti-LAG-3 antibody relatlimab in combination with nivolumab under the trade name Opdualag, which I just recently, or 3 slides ago, described to you. In addition, the FDA has expanded the number of cancer types for which there is at least one immune checkpoint inhibitor approved. The broad utility of these groundbreaking immune therapies is highlighted by the fact that as of July of 2022, 1 or more checkpoint inhibitors were approved for treating 18 types of cancer and for treating any type of solid tumor characterized by the presence of certain molecular characteristics, including molecular or microsatellite instability high tumors, or those manifesting DNA mismatch repair deficiency, and tumors classified as having a very high mutational burden. These are agnostic with regards to tumor type, but the first approvals for tumors that fulfill various molecular genetic criterion. Very important contributions with the immune checkpoint inhibitors. So what do we have looking forward into the future? The advent of many sophisticated modern technology platforms that are now within basic science labs and also being evaluated with clinical samples from patients, single-based functional evaluation of biopsy specimens in situ is surely to enhance diagnostic and treatment approaches to improve outcomes, further leveraging very sophisticated artificial intelligence-based systems, recognition of the importance of the immune system in fighting both liquid and solid tumors, and leveraging the ability to manipulate the immune system to evoke anti-tumor immunity, but also developing liquid biopsy technologies that will enable earlier detection of pre-malignant lesions, or for individuals at risk for developing cancer, monitoring relapse, response, and resistance are sure methods that will improve outcomes further for patients with cancer. We also have to pay attention to environmental, lifestyle, and behavioral factors, including obesity, smoking, excessive alcohol consumption, etc., to further improve outcomes. Recognizing that there are significant health disparities across the cancer continuum, most notably impacting impoverished communities, bringing modern and even standard of care anti-cancer therapies to these individuals will surely improve the statistics further. And with improved outcomes, we have to understand survivorship issues so that we can better respond to these issues, because we know very importantly that the compendium of all of these anti-cancer therapies certainly impact other homeostatic mechanisms within individuals that could, over the long haul, compromise quality of life and otherwise life expectancy. And based upon that, provide better palliative care for those survivors of cancer that have benefited from these remarkable bench to bedside discoveries. With that, thank you very much. And I'm very happy to turn the platform back to you, Dr. Yang. Thank you.
Thank you, Professor Coussens. Really elegant examples illustrating the importance of basic research bench to bedside in advancing our understanding of cancer and also in driving progress in treating cancer. Really, I love the example of Philadelphia chromosome because I live in Philadelphia. It was discovered in the 1960s, and really amazing that it's still generating value over the span of 60 years. Just the pushing generation and the generation of better medicines. Amazing showcase of the patients and the perseverance of our war against cancer. So thank you very much, Professor Coussens. Now, I have the great pleasure to welcome our next speaker, Professor Eric Weiner, President of ASCO, American Society of Clinical Oncology. Professor Weiner is a director of the Yale Cancer Center and also physician-in-chief in Smilow Cancer Hospital at Yale, New Haven. Before that, he was serving in various leadership roles at Dana-Farber Cancer Institute as well as Harvard Medical School. Dr. Weiner is an internationally recognized leader in breast cancer clinical research and clinical care, and has received numerous awards for his great breast cancer research contributions, most notably ASCO's Gianni Bonadonna Breast Cancer Award and Lecture, as well as the William McGill Memorial Lecture Award. His presentation is Progress in Cancer Research and Care, with a focus on HER2-positive breast cancer. Dr. Weiner.
Thanks so much, Dr. Yan. I apologize for my voice. I actually, let's see if we get this right here. 1 second. I actually am recovering from COVID, which I managed to contract in San Antonio. 1 second. There we go.
As far as I know, we have at least 2 COVID infected people in today's summit.
Oh, great.
Yeah.
Well, it's a pleasure to be here. Thank you for having me. I thought Dr. Coussens' talk was really breathtaking in terms of the advances. Mine will be a little different. I'm going to spend just a couple of minutes talking about ASCO and a few ASCO programs. And then I'm going to talk about where we've come in breast cancer, just in very practical terms. I'll talk about where we were 20 years ago and where we are today, specifically focusing on HER2-positive breast cancer, because I think that breast cancer is a little too broad to cover it all at this point in time. So just in terms of ASCO, there are 45,000 ASCO members in more than 150 countries. And as you can see, 500 of those members reside in China. This year, as the presidential theme, we're going to be focusing on partnering with patients, the cornerstone of cancer care and research. This really comes out of my own personal interests over many, many years, and from a strong belief that the relationship between a clinician, whether that's a physician or a nurse, and a patient is a very special relationship, and one that is truly a partnership, not one where the doctor dictates what's going on and the patient listens, but where the two truly work together. I also believe that better relationships between clinicians and patients can result in less in the way of burnout. And so it's not only a good thing for patients, it's a good thing for doctors as well. So as part of this theme, we will talk about supporting better communication with patients, seeking to understand patients' backgrounds and perspectives. Within ASCO, we're focusing on creating an ecosystem of support for physicians. As anyone in the US knows, more and more physician time is taken up doing work that is not about face-to-face interactions. And we need to figure out ways to put the doctor back in front of the patient. I know this problem of limited time with patients is not unique to the United States. And when I was visiting China a number of years ago, I spoke to a Chinese breast surgeon who said that he had difficulty with shared decision-making. And I asked him how many patients he saw each day. And he told me that he saw something like 80 patients in a morning. And if, in fact, you're spending just a couple of minutes with a patient, it's pretty hard to have much in the way of communication. And of course, we have to recognize the absolutely critical role that patients play in cancer research, not just as participants in clinical trials, but in fact, as a clinical researcher, and for that matter, as a basic researcher. If you listen carefully to patients and let them tell you the problems that they face, it can lead to questions that you will ask either in the clinic or potentially in the laboratory as well. I just want to mention that the ASCO Breakthrough Meeting in Asia this year is being held in Yokohama, Japan on August 3rd through 5th. I also want to mention that ASCO offers training programs internationally, such as scientific meetings, Best of ASCO International, various training courses, and other activities. And finally, before moving on to breast cancer, I just want to touch on some of the trends in cancer. I think that Dr. Coussens obviously covered many of the scientific advances. She spoke about the need for equity and the problem with health disparities. In my own view, in the United States, at this moment in time, if we did nothing other than eliminate healthcare disparities, we would do far more in terms of improving survival from cancer than we would by developing 10 new drugs. That doesn't mean we should ignore drug development. We shouldn't. It's not a question of either or, it's a question of both. But we desperately need to pay attention to healthcare disparities. We know that in breast cancer, for example, that a Black American woman who is 20 years of age has twice the chance of dying from breast cancer before the age of 50 compared to a white American woman who is 20. Clearly, targeted therapies are here to stay, both alone and in combination both with one another. although often they are hard to combine, but also in combination with chemotherapy and importantly with immune therapy. And finally, the better and better we do, we learn that sometimes we don't need to do quite as much. And so we need to understand when doing less is better and when we can begin to back off on therapy and avoid some of the toxicities that many of our long-term survivors face. So with that, I want to move on and talk about breast cancer. So now, 30 years ago, in 1992, what did breast cancer look like? Well, at that time in the United States, there were about 150,000 cases compared to 250,000 cases today. There were 44,000 deaths, just about the same as today, maybe a little bit more, but again, with far fewer cases. There was little in the way of screening. Most women presented with a lump or mass. The era of the radical mastectomy had passed, but there was still relatively few conservative surgery operations performed, and many, many women had mastectomies. I've noted from seeing many patients from China over the past 10 years that gradually over this past decade, there is more and more in the way of lumpectomy or conservative surgery in China compared to mastectomy as well. Adjuvant chemotherapy and hormonal therapy were sometimes given. They were in their infancy, and we knew relatively little about who benefited and who didn't, and we tended to treat breast cancer as an all size fits all. All treatments fit all sizes, excuse me. I think the COVID has affected my brain a bit. So in terms of metastatic disease, patients with metastatic disease unfortunately lived a relatively short period of time. The treatment was limited, toxic, and at least in my view, was largely ineffective. Chemotherapy was associated with horrific side effects, and our supportive care was quite limited. Hormonal therapy was limited, and often until just before 1992 involved surgical procedures such as not just removing ovaries, which we still do, but removing adrenal glands, removing the pituitary, and what have you. This was a time, for those of you who are old enough to remember, when the war cry, if you will, was autologous bone marrow transplantation. It was a desperate attempt to try to give massive doses of chemotherapy in the hope of eradicating every last breast cancer cell. While that kind of approach seems to work quite well in the setting of hematologic malignancies and some limited other settings, it was not effective in breast cancer. And there are many women, sadly, who suffered extreme toxicity and lost their lives as a result of that experiment. And at this time, most women who had metastatic breast cancer were highly symptomatic, often had poor pain control. And when I was first starting in my practice, it was very, very common for women to spend truly long periods of time in the hospital. I can tell you that in the United States today, the typical breast cancer doctor at any one time has less than one patient in the hospital. So what has led to the really dramatic advances? And this is where I think that a combination of both science, meaning basic science, and careful examination of clinical trial data and trying to better understand the differences in different groups of patients have together led us to a better understanding. And with that, we've appreciated the biologic heterogeneity of breast cancer and an understanding of breast cancer subtypes. At the same time, and more over the past decade, there's a growing appreciation of the tumor microenvironment, as well as the importance of the host in affecting outcome from cancer, and factors such as obesity, whether they work through creating a different tumor microenvironment or other factors, are clearly very important. So it's not just about the tumor, it's also about the patient. There has, of course, been extensive research both laboratory research and clinical research. And of course, laboratory research ultimately drives most of the clinical discoveries. And there has been truly massive drug development, a huge investment of dollars or euros or whatever currency you use. And of course, in breast cancer, perhaps more than in any other area, there has been huge clinical trial enrollment. And while some of those trials, sadly, in retrospect, have been Me Too trials, and we are not always totally efficient in the way we conduct clinical trials, and that's more so in the past than in the present, I believe. Clinical trials have taught us much of what we know in terms of how to take care of patients today. And of course, the combination of examining clinical data and the evolution in genomics led us to realize that there are really a minimum of 4 very distinct subtypes of breast cancer, each of which contains other subtypes, but those include HER2-positive breast cancer, basal-like or triple-negative breast cancer, and at least 2 varieties of ER-positive and largely HER2-negative breast cancer. So let's use HER2-positive breast cancer to illustrate the progress. So this was the very first trial of trastuzumab or Herceptin in the treatment of patients with metastatic HER2-positive breast cancer. This was conducted in the late 1990s at a time when bone marrow transplant was still commonly given. This was an antibody therapy, which no one thought, or many people thought, wouldn't be effective, and the trial was hard to complete. Not only was the trial hard to complete, but there was an unexpected toxicity, that is cardiac toxicity with trastuzumab, which almost stopped the trial far short of the desired endpoint. But in this study, there was a clear improvement when trastuzumab was added to chemotherapy. And in retrospect, it's a very small improvement given how huge the impact of anti-HER2 therapy has been on HER2-positive breast cancer. And much of the reason may have been that, number one, there was crossover, which limits the ability to see a difference, at least in terms of survival. And number two, testing for HER2 was in its infancy, and there were quite a large number of women included in this study who, in retrospect, did not have HER2 amplified breast cancer and could not possibly have benefited from the randomized investigational arm. Since that time, there have been multiple new agents that have been developed. There has been lapatinib, pertuzumab, TDM1, neratinib, tucatinib, and trastuzumab deruxtecan most recently. Of all of these, they remain in use, perhaps with the exception of lapatinib. So let's just very quickly go through what some of these studies have shown, because I think the really critical point here is that for years and years, we would go to meetings and we would see small improvements in progression-free survival, but no differences in overall survival. And what each and every one of these drugs has demonstrated is an improvement in overall survival, and in many cases, an improvement in overall survival that was seen after a previous line of therapy, which had already shown an improvement in overall survival. This is the Cleopatra trial, which randomized newly diagnosed patients with HER2-positive metastatic breast cancer to receive either the drug docetaxel with either trastuzumab or trastuzumab plus pertuzumab. And what you can see is that there was a significant improvement in overall survival. That improvement was almost a 16-month improvement in overall survival, and an improvement in overall survival that exceeded the improvement in progression-free survival. Now, patients who developed disease progression stopped their study-based therapy. They stopped receiving pertuzumab. And so what this leads one to believe is that somehow early treatment with trastuzumab and pertuzumab led to some impact of the therapy on later lines of treatment. We then had the first antibody drug conjugate that was developed in any solid tumor that came out for breast cancer, and this is the drug TDM1. TDM1 is trastuzumab, which is linked to a small amount of maytansine. And as you can see in this cartoon, the trastuzumab hooks onto the surface of the cell. The molecule is internalized. The DM1 is released, and that leads to a cytotoxic effect with minimal toxicity. And in multiple studies, I just show one here, there was a survival advantage using TDM1 compared to the comparator arm. In this study, it was compared to physician's choice in patients who had received several prior regimens. Then we have the drug tucatinib. Tucatinib is probably the best of the small molecule tyrosine kinase inhibitors. It is essentially a pure HER2 inhibitor. And it also has the feature of extremely high penetration into the CNS. So in this study, patients were randomized to receive either a standard trastuzumab and capecitabine given with a placebo versus the three-drug combination of tucatinib, trastuzumab, and capecitabine. And here, what you can see is an overall survival advantage for the patients who received tucatinib plus trastuzumab plus capecitabine. And of note, this study particularly tried to accrue patients who had central nervous system metastases. And the patients who had brain metastases seemed to do every bit as well as the other patients in terms of the improvement in survival. Even when patients had CNS progression, in those patients who remained on tucatinib, there seemed to be a better outcome. And finally, there has been what many believe is the most remarkable of these drugs, and that is trastuzumab deruxtecan, which goes by the brand name Enhertu. This is another antibody drug conjugate, and I think speaks to the high efficacy of these drug antibody conjugates. What's different about this drug antibody conjugate is, number one, of course, that the payload is different, and it's a topoisomerase 1 inhibitor. Number two, the linker is different. And number three, the drug appears to be somewhat leaky in that once it is internalized into the cell, it then diffuses out of the cell and can affect neighboring cells, which may or may not be HER2 positive. And while I'm only showing you data here from patients who have HER2 positive or HER2 amplified breast cancer, there has also been a recent study demonstrating a very clear impact on both progression-free and overall survival of this drug in patients with so-called HER2 low breast cancer, where the presumption is that the trastuzumab is able, once again, to hook on to the low level of HER2 expression. The drug is internalized, and then by diffusing out, it's able to then attack cells that are HER2 negative. But in this study in patients with HER2 positive breast cancer, this is a first-line study. The primary endpoint was progression-free survival. The comparison was TDM1. And in this study, as you can see, there was a dramatic improvement in progression-free survival for patients who received trastuzumab deruxtecan versus those who received TDM1. And not only was there an improvement in progression-free survival, but as presented at San Antonio last week, there was an improvement in overall survival with a hazard ratio of 0.64, which in my view is really quite impressive. This is the progression-free survival by a blinded independent review committee. Oh, excuse me. This is, I'm very sorry. One sec. I seem to have the wrong slides here. So with that, let me just conclude. Well, although I will say that in yet another study, a study that compared trastuzumab deruxtecan to patients who had had even more therapy, patients who had already progressed on TDM1, there was also in that study in improvement in progression-free survival and overall survival, once again, as presented at San Antonio last week. Those were the two slides that I thought were there, but apparently were not. I'm sorry. So where have we come in HER2-positive breast cancer? Well, there are multiple effective and reasonably well-tolerated therapies. With appropriate treatment, survival for patients with metastatic disease, which used to be well under 2 years, is generally more than 5 years. In many cases, it's 10 years and beyond. Brain metastases remain a large problem, and about half of all patients with metastatic HER2-positive breast cancer develop brain metastases. Tucatinib, for that matter, as well as trastuzumab deruxtecan, appear to be quite effective in the treatment of brain metastases. We have local therapies for brain metastases, but we need two things. Number one, we need better therapies for brain metastases, but we also need to have a better understanding of the underlying biology of brain metastases, because in fact, there is some suggestion that the tumor microenvironment in brain metastases may really be quite different and may require different approaches. Although we didn't discuss early stage disease, the truth is that the vast majority of patients with stage 1 through 3 HER2-positive breast cancer are presently cured. If you are a patient with stage 1 HER2-positive breast cancer, you can receive fairly limited chemotherapy and trastuzumab with the chance of remaining disease-free indefinitely that is probably well over 95%. And the numbers are not substantially worse, even for patients who have stage 2 and 3 disease. And in this setting, the major question is becoming, for those patients who do so very well, how can we figure out who needs less and who might need a little bit more or something that's a little bit different? And finally, we need desperately to work to deliver these treatments to all patients who need them. And here, I'm not talking about the United States alone. I'm talking about around the world. These are inordinately expensive drugs. It boggles the mind how we are going to pay for them for women around the entire world, but it is so important because these are life-saving drugs and they truly make the difference between life and death. And we do need, as we develop better and better therapies, to work tirelessly to eliminate the healthcare disparities that exist, again, both in the US and elsewhere. Thank you very much. I appreciate you having me.
Thank you, Professor Weiner. And first, we all wish you a speedy recovery from COVID. It is truly incredible to see how innovative medicines are transforming the lives of patients with HER2-positive breast cancer. And really seeing the p-value of 10 to the minus 22 in the clinical trial is really, truly gratifying experience for investigators, drug developers, and of course, most important for our patients. So let's now move on to our panel discussion. So besides our speakers, we're very fortunate to have Professor Ying Mao, President of Huashan Hospital, Fudan University, to join us. A brief introduction of Professor Mao. Professor Mao is a well-achieved neurosurgeon. He was voted as top 10 best physicians in Shanghai. In addition to operating as a surgeon, Professor Mao is also a leader in the field of clinical research focusing on neuroscience, cerebral vascular neurosurgery, as well as neuro-oncology. He has authored more than 500 papers, reviews, and book chapters. It's great to have you, Professor Mao. Right. So, because several speakers during your presentation all mentioned the early diagnosis. So let's get started here. So early diagnosis, of course, is the best approach to detect and treat cancer while the disease is still in their early stage and it could be potentially cured, as Dr. Weiner illustrated for stages 1 to 3 HER2 breast cancer. So Dr. Coussens, you mentioned that one of the future breakthroughs could be coming from developing liquid biopsies for early detection, monitoring relapse, response, and resistance. So in your opinion, briefly, do we only focus on cancer cells, or can we also think that surrounding cells and the tissues, such as inflammatory cells, could potentially also teach us and generate useful information in liquid biopsies?
I couldn't have paid you more to ask me that question. So thank you very much. My research area of expertise is understanding the complexity of relationships between various types of immune cells with neoplastic cells, and understanding how they communicate with one another and regulate pro versus anti-tumor activities of all of the compartments within the tumor. I have hypothesized for many years that if we could understand the systemic immune response to disease and learn how to read the immune system as a sensor molecule in individuals at enhanced risk for cancer, certainly in aged populations, that would provide a significant diagnostic potential for further screening or more intensive monitoring of individuals for the emergence of premalignant disease. I don't think we hold a better sensor system within our bodies than the systemic immune system in circulation in all individuals. We just have to learn how to interpret it.
Great, thank you so much. Dr. Weiner, so from a clinical oncologist perspective, how early do you think that we could detect a cancer with sufficient sensitivity and specificity using the liquid biopsy approach that would be clinically meaningful in your opinion?
Well, I think the challenge is that I suspect we are going to be able to diagnose cancers very, very early as the sensitivity of these liquid biopsies increases. I think in many cases, it may be early enough that we have a hard time figuring out where the cancer is. Now, perhaps that will be solved by being able to characterize the biopsies well enough so that we will know. But even in that case, I don't know quite how we treat a breast cancer that we can't see, touch, identify. Now, that doesn't mean we shouldn't pursue this from a research standpoint, but we're just going to have to be very careful about how we approach patients, or there is the potential for harm. We also have to think about when we need to find something very, very early, something that is potentially lethal, and when we're dealing with a cancer that is fundamentally far less lethal, and finding it a little bit later will not be a difference.
Right, thank you. Dr. Fan, you talked about the holistic approach in terms of cancer detection, treatment, management. So from your viewpoint, are there any downsides in our efforts in trying to detect cancer earlier and earlier, such as unnecessary patient anxiety, over-treatment?
Yeah. So it's a very good question. Yeah, because as a clinician, I work up to now, I'm 70 years old. So my opinion is, so my question is, what is early? Because everybody has the cancer cell in his body. So what time we should to say she is early cancer or not? Because we should very carefully we mislead the patients and also the medical field. I will tell you a story. In Korea, within the 10 years, the incidence rate of the thyroid has been increased 19 times in China as the same, because the ultrasound diagnosis and other, right? So the people concerned the rate, the survival 5 years survival rate. For example, in USA, but we put a lot of early patients into the count to increase as 5 years survival. But most of them can survival much more than 5 years without any medical intention, right? So this contribution not from doctor, right? So so in the future, I think we should pay attention the not rate, but the absolute of number of the days. Other words, if all of the technology has become, the hospital earn a lot of money. Now we are satisfied with our 5 years of survival, but the days is still same. So anyway, so I'm not against or neglect the early screening, just like I told, right? But if we found the early stage, the patient has a 3 phase. One is that 1/3 will progress the cancer, the advanced stage cancer, 1 stage disease of it, and maybe some they come back, right? So when you find some the early case, how can you do, right? That is it. We just do something for the cases who will progress to the advanced cancer. That is better. So that is a discussion in the future. That is also CACA guideline discuss about that. Thank you.
Great. Thank you so much. Dr. Weiner, actually, in your presentation, you mentioned that brain metastasis from breast or from lung cancer patients, right, is clinical particularly challenging for medical oncologists. So I would like to ask Dr. Mao, what are your thoughts about using liquid biopsy to predict the patient's risk of developing brain metastasis? And what are the particular challenges?
Yeah, okay. Actually, I totally agree with Professor Fan that I'm a neurosurgeon. I just mainly for the surgical resection of the glioma. So we just pay less attention to the early diagnosis of the tumor because the glioma has a really metastatic to the other part of the body. So I think that the liquid biopsy is maybe useful for us to predict the recurrence of the glioma, but actually the liquid biopsy in brain tumor, we just focusing on the CSF, not the blood test. Blood test is maybe not very sensitive for for us to test the recurrence of the brain tumor.
Thank you so much. And I do have a question from the audience, actually. By the way, I heard we have probably 1 million audience online through different stream channels. So this is one of the questions from the China live streaming platform. The question is, the next generation sequencing big panels often detect mutations that are not druggable. So the question is, are these really meaningful in terms of guiding the treatment or management of cancer patients who harbor these mutations? Who wants to take this question? I guess Dr. Weiner.
I'm sorry, can you just repeat that again? I didn't think you were asking me.
Oh, the question is, in the next gene sequencing big panel detection, it will often reveal that there are multiple mutations that are not druggable. And are these mutations meaningful in guiding the clinical management of these patients who harbor the mutation?
Yeah, well, at the moment, I think they're not, but the question is whether they will be in the future. And, as you know, for example, in lung cancer, there are multiple mutations that, of course, guide clinical management. In breast cancer, there are relatively few, but interestingly, more than there used to be. And so I think it's a matter of time before this more precision type oncology approach is applicable to many, many different kinds of cancer.
So it's useful for research, but not for immediate management of the patients at this moment.
Well, I will tell you that, for example, in breast cancer, we pretty routinely obtain sequencing to look for HER2 mutations, in some situations to look for ESR mutations to know when we shouldn't be giving an aromatase inhibitor, and increasingly to look for mutations, somatic mutations in BRCA1 and BRCA2, and then of course there's PIK3CA.
Mm-hmm. Yep, great. Thank you so much. The second theme I heard from other speakers is united we're stronger, united we can go faster, right? So Dr. Semenza, you have been training young scientists from different countries, including from China for many years. Dr. Wang, who contributed to your seminal research of HIF-1 alpha in a PNAS paper, is one of the examples. Could you comment on the importance of global collaboration in basic research, and how would you like to see such collaborations to continue and to improve?
Well, certainly, science is based on one discovery building on the next, and the open exchange of information, of course, is critical for advancement in science and the translation of basic science into in new therapies. We've had the benefit in the U.S. for having being able to recruit students from all over the world and to help drive our research engine. Now, countries like China are joining that effort, and I think that our abilities to collaborate with labs all over the world is critical for continued success. And frankly, I don't see anything really getting in the way of that. Scientists, I think, get along just fine.
Great. Thank you so much. Being united is not only just collaborations across borders of different countries, but also means, especially in clinical collaborations across different disciplines. So I would like to invite Drs. Mao and Dr. Weiner to comment about molecular tumor boards, as well as multidisciplinary diagnosis and treatment approaches in your cancer centers, respectively. Specifically, I would like to ask, what are the challenges you're encountering in this approach, MDT approach, and what improvements would you recommend helping patients get better diagnosis and treatment using this multidisciplinary diagnosis and treatment approach?
Okay, go ahead.
You go ahead, please.
Okay, I just the situation right now for MDT is maybe different from the United States and from China, and especially for the neuro-oncology. The United States, we have a lot of neuro-oncologists. But right now, in China, we have the MDT team, but was lead by the neurosurgeon. So this is a very totally different, because the United States, maybe the oncologist just control the further treatment and also the molecular classification of the patient, and also finally just to suggest the patient to see the doctor to do the surgery. But in China, the situation is different. The surgeon just to do the surgery and ask the patient to have this molecular classification, and then we transfer the patient to the oncologist. And at that time, the surgeon still control the whole progress of the patient. So we just organize the MDT based on the treatment by the surgeon. So this is totally different. But I think that maybe the all kind of situation, maybe it still have some it's maybe meaningful in different situation. So right now, in China, I think that this is a very useful. So that's why we think that we try to have the guideline in China maybe differently. But sometimes we just have a different flow chart and different procedure. But the main course is that we still have to do the MDT diagnosis and treatment. So right now it's very popular in the main cities in China. The MDT is very important. Yeah, wind up, please.
So I'll provide my U.S. perspective. Apart from patients with hematologic malignancies, where there really isn't a need for a surgeon, and most of the time there isn't a need for a radiation oncologist, in virtually all the solid tumors, there's a need for all of the disciplines to be involved. Now, that doesn't mean that every single patient is always going to get a systemic therapy. And for that matter, there may be times when a patient doesn't get a local therapy, although much of the time they certainly do. And from our standpoint, it's really standard of care for multidisciplinary teams to exist. It doesn't mean that it's entirely easy, because you need to get 2 or 3 different clinicians from different fields working closely together and cooperating. And in the ideal world, you want all of those doctors seeing the patient on the same day. That doesn't mean they have to all see them in the same room together, but it means that a patient shouldn't have to come back 3 different times on 3 different days to see 3 different doctors. And then a plan needs to be developed. I think that over the last 10 years, this really has become the norm, and any place in the US that isn't practicing in this way is really falling behind the proverbial 8 ball. In terms of molecular tumor boards, these too have become more and more common. I think they're as much educational as they are practical, but they can be very, very helpful. And of course, for many oncologists, understanding the results of tumor sequencing is pretty challenging. And so what the tumor boards can do is both shed light on an individual case so that decisions can be made in real time, but also, as I mentioned, provide education. So, I think in these ways, oncology has really moved a fair amount over the last 10 or 15 years.
Great, thank you. Anybody else from the panel would like to comment on this question? No, if not, I'll ask the last question, because the third last theme I heard from other speakers is really the equality in terms of access to these transformational medicines, right? So we could start with clinical trials. So conducting clinical trial is really the most important thing to get these medicines approved. Dr. Wang, you are a clinical trialist, in addition to be a clinical oncologist. And as a president of ASCO, what do you think will be effective steps that could help patients from different social classes, as well as from different countries and regions, gain equal access to clinical trials of potentially transformational new medicines?
Well, of course, the single biggest change would be to equalize care for everyone. Because if in fact everyone is receiving equitable care, then clinical trials will simply be available to everyone. And so if you provide the best care, then clinical trials will be part of it. That said, I recognize that it's going to be some time before we eliminate cancer care disparities. And in this period of time, while we're working on that problem, and that problem is going to take years to fix, we still need to pay attention to the fact that the clinical trials population needs to be representative of the general population, or we won't know whether the impact of our therapies is similar across different racial and ethnic groups. And so in that context, we have to make special efforts to include patients in trials. Perhaps the single most important thing we can do is, or the 2 things we can do are, 1, we can ask patients to be in trials, and it's been documented that patients from different racial and ethnic groups are less often asked to participate in trials. And then we need to make sure that the trials are simple enough and accessible enough so that a patient can participate in them. Because if you have trouble getting transportation to the clinic, if there are too many eligibility criteria, and because of the way your life has been, you have one or more comorbidity, then it may be more difficult to participate. So we have to think about how to make the trials more inclusive for everyone.
Thank you. I would like to invite Professor Fan and Professor Mao to provide your perspectives from China.
Okay, so I also get questions from audience. So Dr. Yang, so the audience in the virtual has over 4 million.
4 million.
Up to now. Wow. Yes, including my platform. The question is, the question or comment is just like that. That means in the future, for the clinical trial for the new drugs development should be a focus on the people who are not effectively treated. So now, if there are some the procedures and the drugs we have existing and effective for that group, we don't need any the new drug, new procedures. There is a saying in clinic, just the increased procedures and drugs cannot affect any surviving. That is true. So in the future, we should, for the clinical trial, the indicator for a new drug and new individual should be focused on the group who are not effective by other methodology. Why? Because recently we developed the CACA guideline, the technique version. So we found that for the cancer, we have so many methodology to treat it. Now each one has the cure rate at 20% or 40% for the 100 people. So total, if we put them together, so maybe not 100% cure rate, but several 100% the cure rate. But in fact, only the 40 or 70 people can be treated. So that is a comment or suppose that in the future, including ASCO and the CACA, if you have some new drugs, a new procedure should be for the new patients which cannot treat effectively. If otherwise, if you are cheaper, you are less side effect, and so on. At the last, I would like to also the question to me is, I don't know you have or not. That means that CACA can be used in lower income countries. So my answer is, we are thanks for USA or other countries who have developed the guideline. We introduced this guideline to solve the 40% of patients which have the 5-year survival, but for the rest, 60%. So we cannot do nothing. We have to do something by Chinese way to solve that one. After we get some results, we also can reward it, like USA for the 30% of days. And also this can be introduced to a low income countries, because maybe they made the same problem just like China. So that is we would like to say. So I help you to answer the question from audience. Thank you very much.
Thank you. Well, this does address the treatment equality issue, because some of the low-income countries, patients may have maybe facing similar challenges as patients in China rather than compared to patients in the U.S. So thank you. Dr. Ma, anything to add?
Yes, I think that the clinical trial is very important, not only for the new drug, but also for the combination of the therapy. So right now, so I think that we just realized that the subtyping of the tumor made the clinical trial very difficult. We really hard to recruit the candidate. So I think that suggests, because right now we have a very good relationship with ASCO, because a lot of oncologists just visit the United States to attend the meetings. So I think that why not we can just organize such kind of the clinical trial, and at the same time in United States and in China. And because we have a huge population and have a really good candidate, and we can compare the PFS and the OS, and also this is maybe can shorten the time for the new drugs to the market. So I think that maybe that's why the United is very important for the clinical trial.
So I add one sentence, Mr. Yang. So I agree with Dr. Mao, because we in China, we have a huge population. We have also huge patients, even the rare cancer. So if USCACA, so you have some new drugs, new procedure, we can collaborate with you. It's very easy. It's not just to do some research in RCT, the 200 patients. No, sometimes it's a biopsy. Thank you very much.
Yeah, great. Multi-country, multi-regional clinical trials. That would be the topic we could, of course, organize together with ASCO AACR. So I know we're 15 minutes past. So before we close, I would like to invite each of our distinguished speakers and panelists to give one brief remark to our over 4 million audience online. Who wants to start? Dr. Weiner?
Sure. And I'm sorry, but I'm going to have to leave after this. I think that what is going to be critical as we move forward is for there to be as much collaboration as possible across the globe. And the world really is pretty much one entity. And from a cancer standpoint, we need to be doing research together. We need to be developing the best standards of care together. We need to recognize the differences that exist both in populations and in practice patterns. But we really can't allow ourselves to have major differences in the way people are taken care of in different parts of the world. And so I think sessions like this are really great.
Great. Thank you so much.
I'm going to go.
Thank you, Weiner, Dr. Weiner, and have a speedy recovery.
Thank you.
Thank you. Professor Fan?
Yes, in sort of in the world, there is not a complete right sense in the word how to do supplement to that effect. The bi-collaboration that will lead our future together. We hope that very closely collaboration, exchange. We hope next year. Thank you.
Great, thank you. Who wants to make the next remark, please?
Yeah, I'll go because I also need to sign off. Reiterate my thanks for inviting me to participate on behalf of the AACR. But I want to echo what Dr. Weiner also said, and that I think collaboration is the key. Gone are the days when basic scientists can do solo science in their own laboratories. It's simply too expensive with modern technologies, the need to have embedded computational scientists, but also to have embedded collaborations with clinical folks for preclinical studies that actually model human disease, and the ability to have access to patient samples so that hypotheses that were generated in the lab can be tested in the penultimate experiment, that being the human And collaboration, utilizing platforms like this can only improve the quality of the basic research, but also drive drugs to patients with more than just cancer to the clinic to improve outcomes for all of us.
Great. Thank you, Dr. Coussens.
Thank you very much.
Thank you. Dr. Semenza?
Yeah, well, we've heard about the recent discoveries of new drugs and improvements in survival of cancer patients. And I think the next 5 to 10 years is going to see a dramatic improvement in both cancer detection and therapy. I think it's going to be quite dramatic, and I'm really looking forward for these new discoveries to make it to the clinic. And I think we'll be seeing that in the next several years. Definite case for optimism.
Great. And my best wishes to your drug as well.
Thank you.
Professor Mao.
Yeah, I just try to use the words from Professor Fan. I think that the tumor treatment need integration. So I think that cooperation is the future. Thank you.
Great. Thanks. Thank you so much. So before we close, I really, thank all our panelists and also thank all the audience staying online. I would also like to thank our colleagues at eChina Health for all the behind the scenes hard work and the generous support from Jen Chuang to make this event possible. I'm very confident that this CACA and the USCCA summit next year will be offline and we'll see you in person. Happy holidays, everyone, and we will see you again next year. Goodbye.
Bye-bye.
Bye-bye.